You are looking at the impact of what's called the dedicated geriatric oncology service. Let me ask you first of all, because you've done a study on this, how common is it that there is a dedicated service for older patients with cancer?
So at least in the Australian setting, a dedicated geriatric oncology service does not exist in majority of the hospitals. So Royal Adelaide Hospital was the pioneer institute in Adelaide in Australia, where geriatric oncology services were laid out for the first time and have been gradually expanded to 2 or 3 other institutions as well. And Royal Perth Hospital is one of the institutions in Western Australia where we did this study. So in terms of what a dedicated geriatric oncology clinic means is that we sent out a comprehensive screening questionnaire to the patients, which was posted out to them at the time of their first appointment, and they filled it with the help of their family and friends and brought it to their first clinic appointment to give us a more comprehensive information about their functional status, which assists us in ability to make informed decisions which are rational and to avoid over-treatment or under-treatment of older cancer patients.
Right, so in practical terms then, there was a questionnaire. What else did you have to do to execute this study?
So once the questionnaire is brought to us by the patient at the time of first consultation, we go through it. So that's one part of the assessment, and then we go through the cancer assessments part of it, and then try to join them together to make to get an idea, okay, what the disease for this patient is and what is the functional status of this patient, and try to look at the patient as well as the disease and try to make a better informed decision about the ability to undergo anti-cancer therapy, whether we should treat this patient or not.
And why should that be crucially different for older patients as compared with their younger counterparts?
So older patients have got complex care needs. And age is an age bias exists amongst physicians. But we know that older patients is quite a heterogeneous group of patients in terms of their functional status and in terms of their comorbidities. So every 80-year-old is not the same 80-year-old. We see a relatively fit 80-year-old patient. We see very frail 70, even 60-year-old patients as well in the clinic. So with the help of comprehensive geriatric assessment, we're trying to identify which we will not identify on routine history and physical examination in a general medical oncology clinic. Whereas in contrast, in geriatric oncology clinic, we get a more comprehensive picture of the functional status of the patient, their comorbidities, the medication they are on, and try to rationalize everything.
So that's the theory. It should be good. It should be worth doing. Yeah. What, in fact, did you find?
So a lot of studies have been done looking at what type of geriatric assessment can be done. There are a lot of different tools available. So essentially, I think as long as some shape of geriatric assessment is done, that's reasonable, and it's recommended by NCCN and SIOG for every patient who is age 65 and above. So in this study, what we've looked at is to assess its impact, because that's the question when you're trying to roll out a geriatric oncology service. The first question when you're applying for funding for such a service is from the administrative authority is, okay, what difference will it make? And obviously, so far, we haven't been able to come up with a plausible explanation what difference will it make. And the thing which is more appealing for the overall health system is what impact comprehensive geriatric assessment will have for an individual patient and overall onto the health system in terms of cost saving. So we look specifically at the number of unplanned hospital admission, as well as the average or the mean inpatient length of stay of these patients, and try to find out whether there's any difference in contrast to patients seen at the same time in the same hospital but through a general medical oncology clinic who did not undergo geriatric assessment.
And in a nutshell, what was the difference between the rates of unplanned hospital admissions and the length of stay, depending on whether you had a geriatric assessment or not?
So we found that, so this is a pilot study, it's a small sample size, and there are a lot of caveats and limitations of this study, which I will elaborate in my talk later today as well. But essentially what we found was that the rate of unplanned hospital admission was much higher in patients who were seen through a general medical oncology clinic in contrast to a geriatric oncology clinic. So roughly about 37% of the patients did not have any admission who were seen through a general medical oncology clinic. In contrast, patients who were seen through a dedicated geriatric oncology clinic, 67% of the patients did not have any admissions at all. And then also patients who had at least 1, 2, 3, or 4 admissions, the number was higher in patients who did not undergo geriatric assessment.
Does this mean that there was a saving overall, not only in terms of cost, but also patient morbidity?
Yeah, so in terms of patient morbidity, which is secondary endpoint of a study, which we present the data sometime next year, but in terms of the primary data, there was a reduction in the rate of unplanned hospital admission, and in terms of the cost saving, the average inpatient hospital stay was about 5.5 days for those seen through a dedicated geriatric oncology service, in contrast to 11 days for patients who did not, who were not seen through this dedicated geriatric oncology service. And putting it in perspective, I mean, the numbers are very sort of crude and very vague, but just to give you some idea, an average inpatient bed stay for a hospital in Australian health system costs about 2,000 Australian dollar. And when we look at the cumulative length of stay between the two groups was 334 days versus 665 days between the two groups. That's a difference of about 339 days. And if you multiply it by 2,000 Australian dollars, so roughly equates to about 668,000 Australian dollar or 443,000 euro day saving to the health system. Now these are very rough figures. There are a lot of pros and cons in terms of how we interpret this data, but gives you some impression that we can save a lot to the health system and also avoid morbidity to the patient by making rational decision if we know our patients very well.
Right, it's a massive impact, in other words,
Yes.
from your small study, relatively small study,
Yeah.
but a huge difference. So
Yes.
I think the significance is
So
quite
so this is
established.
Yeah, so this is a pilot study. What we are trying to do is, subject to funding which we applied for, we are trying to do a randomized study of about 270 patients in which we will randomize these patients. And then in the pilot study, we looked at all the different tumor types, whereas which confounds the data and makes the interpretation a bit difficult. Whereas in the randomized study, potentially will include patients with major tumor types like lung cancer, bowel cancer, prostate and breast cancer, and then randomize them 135 patients to each arm, and then follow them up for a period of 12 months and see if there's any difference in terms of the rate of unplanned hospital admission, length of stay in the hospital, treatment-related adverse event, and then short-term survival as well at 6 and 12 months to give us a better idea of what this is all about.
In a nutshell, then, how would you sum up the importance of what you're saying, or the key messages coming out of this for cancer doctors?
I think that the key message is that we should not be biased against older cancer patients. We should make treatment decision more rationally once we are much more informed through these older cancer patients, because they got complex care need. We should assess them more thoroughly through a comprehensive geriatric assessment. Once we identify any deficiencies, any of the domains of the comprehensive geriatric assessment, we should try to address it through a multidisciplinary team meeting and try to make appropriate referrals to try to address them, like to refer a patient for a physiotherapy assessment if they are having repeated falls, or refer them to a dietitian, particularly in the context of gastrointestinal cancer. And then I think overall this will avoid over-treatment of frail patients and under-treatment of relatively fitter older cancer patients. And then this will overall lead to huge cost saving to the health system.